Our guest speaker today is Joe Martin, and he is the Chief Security and Privacy Officer for Medical Informatics Engineering. He has quite a bit of experience and tenure in this area, and is not only responsible for managing the security and privacy of their corporation, but also for client data. So I will turn it over to Joe, and as I said, please, your lines are muted, but please feel free to submit your questions through the chat. Thank you.
I've spent about 30 years post-college in the IT field, and about the last 16 or so specifically covering security and privacy. I started, I was working with IBM at the time and started doing security and privacy coincidentally the same year that the HIPAA legislation was passed in 1996. And I've really been with it from the beginning, which is I don't know if that's a good thing or a bad thing, but it is what it is. There is no hard and fast rule as it relates to the security risk assessment, and we'll talk specifically about that, but also around protecting health information in general. For those of you who spend any length of time in this space, you'll know that the legislation that's been passed in this area, specifically HIPAA and the administrative simplification provisions of HIPAA, and then the extensions that have come along with the HITAC Act in 2009, as with most government legislation, they're very vague and non-prescriptive in terms of what the requirements are, and that's by design, because partly it's because the government knows that over time the specifics of how you deliver on protecting health information, both from a security and privacy standpoint, those specifics are going to change, and it would probably be inadvisable for them to write specific legislation mandating certain things be done, knowing that the technology is going to make those things obsolete in a fairly short period of time. So the legislation is rather vague and non-prescriptive, and it's really up to us as organizations that are subject to the rules that the government puts in place to protect health information, are doing our due diligence to understand what our risks are, and also to apply the appropriate security controls. And as we do that, it's incumbent upon us to make some of those decisions about what we feel is appropriate given our situation. And then potentially, at some point in the future, an audit organization may come through and question why we made certain decisions and maybe recommend others. And we'll talk more about that in a few moments. But again, the point I wanted to make is there are no right or wrong answers. There are certainly some industry best practices, and those are important to understand, and we'll talk about some of those. One thing, sorry, wrong button. One thing that I wanted to give you just as background, and this is not intended to be a sales pitch for our organization as much as it is to let you know kind of where I'm coming from. As I said, I've spent my entire career in the IT field, in the last half of it at least, in the security and privacy arena. In my role with Medical Informatics Engineering, MIE is a healthcare IT company really made up of two organizations under the same corporate umbrella. There's Medical Informatics Engineering, which is an organization that provides electronic health records in the ambulatory space, as well as an extension of that we've added occupational health surveillance to, that we market to large organizations who have their own employee health clinic. Eli Lilly, Dow Chemical, Concentra, several large clients fall into that category for MIE. But the point I wanted to make is it's fundamentally a SaaS model, software as a service model, what may have in the past been called an application service provider model, or sometimes referred to as a cloud, kind of a cloud model as well. So as Eldrina said in the introduction, not only do I have responsibility for protecting MIE's corporate assets, but because we are a SaaS vendor, we serve as a business associate to covered entities, so it's incumbent upon us to protect their data as well, as we're required to as a business associate. The other thing I wanted to mention is under the corporate umbrella, there's also a personal health record company called NoMoreClipboard.com, which some of you may have heard of. At least I hope you have. And in the whole context of meaningful use and patient engagement, No More Clipboard's been around since 2003, has gained tremendous interest in the marketplace in the last 18 months because of patient engagement elements of meaningful use. So that's the corporate context that I come from. And again, my role there is multifold, but specific to this conversation, I'm the Chief Security and Privacy Officer. And as I mentioned, we're a HIPAA business associate, and obviously subject to those requirements, both from HIPAA and the HITAC Act extensions to HIPAA. That's enough about context setting. Let's talk more about the specific topic. And while I know that most of your interest is around security relative to meaningful use, I wanted to cover a couple of topics relative to security and privacy that really came together at the same time, because I think you have to look at it in the broad context, not just specific to meaningful use. In the HITAC Act of 2009, which was, as all of you are aware, was part of the ARA stimulus package in early 2009, there were a couple of different things that came along in that legislation that are important and that we care very much about today. One, the obvious one, was the meaningful use legislation, specifically the Medicare, Medicaid, electronic health records, EHR incentive programs, again, typically known as meaningful use, and I know you're very focused on that, as are the RECs. The other thing that was part of the HITAC Act, which was equally important for me and for others in a role similar to mine, was the extensions that the HITAC Act brought with it to the HIPAA legislation around security and privacy. So again, for the sake of context, HIPAA was passed in 1996, became required. It became required that you comply with the security and privacy legislation as covered entities early in the 2000s, and then in 2009, and this is my perspective, this isn't an official opinion, but from my perspective, what the HITAC Act of 2009 did, at least the Subtitle D part that addressed security and privacy, was close some of the loopholes or the perceived loopholes that existed within the HIPAA legislation to begin with. So among other things, it increased the penalties across the board. It added a breach notification requirement, a security breach notification requirement, which is specifically why you see all these reports of security breaches in the healthcare IT field. It's not necessarily for good or bad. It's not necessarily because there are more breaches today. That's arguable, I guess. But you're seeing more breach notifications because it's now required by law. So the Subtitle D of the HITAC Act brought in the security breach notification requirement. There's some accounting of disclosure changes that are rolling out, fewer loopholes. One thing that was very significant to us is that under the original HIPAA legislation, covered entities were specifically covered with both criminal and civil penalties under HIPAA. Business associates were only covered via contractual requirements to a covered entity and really only had a civil component to their potential penalties. The HITAC Act or Subtitle D extended all of the same requirements to business associates that were originally extended to covered entities, including both the civil and criminal penalties enforceable by the U.S. government. So there were a number of changes that happened around security and privacy in the healthcare field, not only the requirement to do security risk analysis as part of the meaningful use attestation. So just wanted to, again, in the interest of context setting, there's a lot that's going on, has gone on the last couple of years and continues to go on. But if we look at meaningful use specifically, what's formerly known as the Medicare, Medicaid electronic health records incentive programs, obviously funded by the federal government to incent healthcare providers to move to electronic health records, and then obviously first year is 90 days, and then subsequent years are the full 12 months. So in the first year and in the subsequent years, under stage 1, you have to register, and then you have to run for your required period of time, and then actually do your attestation. And I know because most everyone on the phone, I suspect, has been working closely with your REC in Arkansas. This is probably old news to you, or it should be, but again, it's kind of in the interest of context setting and drilling down into the specific requirement. You register, you utilize the EHR, and then you attest, and you receive your payment. It's that simple, and I say that somewhat facetiously because we know there's a lot of work behind that. However, during the attestation part, you have to attest to 15 core measures, 5 of the menu set measures, and then 6 of the clinical quality measures. And one of those 15 core set measures, particularly one that's important from my perspective, is the protection of electronic health information, or the security core measure, and that's the one we'll talk more about now. I don't know what the source of this chart was originally. I certainly didn't create it, and I credit whoever did. It's not perfect, but it kind of gives you, there's a glaring piece of information here that I think you probably all jumped right to. It's the thing that attracts your eye most quickly. Someone had done this bubble chart that kind of shows each of the core measures and each of the menu set measures under meaningful use, and they've created the bubble at different sizes depending on the amount of effort that's perceived. So during a given attestation cycle, there's some amount of effort that someone has attributed to each of the different core measures, which are in blue, and the menu set measures, which are in pink or red. And the glaring piece of information that jumps right out at you is by far the largest bubble, much larger than any of the others, and these are not exactly to scale, as you'll see, but certainly the one that's perceived to be the greatest amount of effort to comply with that particular measure is core measure 15, or security, or the protection of electronic health information. And the individual who did the analysis had estimated approximately 6 hours of effort to comply with that particular core measure, as compared to others which are measured in minutes up to, I think maybe the next closest one is 1 hour. And again, I'm not suggesting that 6 hours is the right answer. I'm just suggesting that many people who are looking very closely at meaningful use certainly understand that one of the toughest pieces of attestation, or the toughest pieces of work effort in order to get to attestation for meaningful use, is the security risk assessment. And given that I've been involved with meaningful use from the beginning as well, not just in the context of security, I certainly wouldn't disagree with them. So let's talk about core measure 15, specifically the security measure. And I've pulled some CMS-specific documentation into this presentation because as those within our organization who I work with know, that whenever a question is asked, or whenever I need to do any research at all about meaningful use, I go straight to the CMS documentation. I don't read, at least I don't read initially, other industry assessments of what the requirements are, et cetera, because I found out early on in the process that many of those industry assessments of what was required for meaningful use and what wasn't were incorrect. So I always go directly to the source, often to the Federal Register where the information was published originally, or certainly to documents that are put together by CMS, given that it's a CMS program. So again, you may have seen some of these. I would encourage you to spend time with them if you haven't. One of the documents that CMS put together covered each of the individual measures and some high-level information. Core measure 15 is the security measure, which is specifically stated as protect electronic health information created or maintained by the certified EHR through the implementation, and the emphasis is mine, appropriate technical capabilities. The measure is actually intended to be the conducting of a security risk analysis or reviewing one that's been done within the last 12 months. That's the other part of the provision. Conduct a review of security risk analysis in accordance with the requirements under 45 CFR 164.308. I'm not going to, if I were in an audience face-to-face, I would quiz you to see if you could tell me what 45 CFR 164.308 is, and I suspect you probably know, but that's specifically the HIPAA security rule, and that's the security risk analysis that meaningful use is referring to. Now, a risk analysis in and of itself is a wonderful thing. However, really all a risk analysis is designed to do is to identify the problems. What you then need to do is also implement security updates as necessary to correct the deficiencies that are found. So it's only half the effort to identify what the problems are. Then you have to implement the security updates or security controls as appropriate. So, additionally, in the CMS guidance, they have a definition of terms, and there was a typo in the CMS document that I couldn't change, so I just referred to it. But so the appropriate technical capabilities, this is a definition of a term used in the specific rule, would be a technical capability that would be appropriate if it protected that EHR information created and maintained in the technology. These capabilities to protect this information could either be part of the technology inherently, and many of them are, and we'll talk about the reason for that is because ONC, when they put the certification requirements together for the technology, when they actually went through the certification of an EHR, they had a number of security controls built into that certification process. Certainly not everything you would possibly need, but certainly the core requirements are built into the certification. So by definition, if you're running EHR certified technology by ONC or by an ONC ATCB, like MIE's web chart system, you would have all of the capabilities that ONC determined appropriate as technical controls built into the software. You can address those capabilities using the technology that's part of the software package, the EHR software package, or by outside systems and programs. As long as you address the requirements, they don't care how you do it specifically. In stage one, this is an attestation requirement, and it may continue to be in later stages as well, but those are still being worked on in terms of detail. In stage one attestation, this particular core measure is a yes-no attestation. You say, yes, you have conducted or reviewed a security risk analysis, or no, you haven't. Now, while the attestation portal allows you to answer this question no, you certainly wouldn't meet the requirements of meaningful use and wouldn't be eligible for payment if you answered no to this question. So once you get to the portal and you're going through attestation, I would tell you, unless you can truthfully and comfortably answer yes to this question, you probably aren't quite ready to go through attestation yet. But that's really the process that you would go through. They added some additional information in the CMS guidance as well, and I'll just hit the highlights here. The eligible professional, the individual who's actually going to get paid by CMS for meaningful use, must conduct or review, and in most cases, the EP is probably not going to be conducting a risk assessment, although they could. More likely, they're going to be reviewing one that someone else within the organization has done, maybe the privacy or security officer for the practice, or with outside assistance, such as from the RECs. But the EP must conduct a review of the analysis, ensure that updates are implemented as necessary at least once prior to the end of the EHR reporting period. And they do say that for example, if you were intending to do 90 days of meaningful use in 2011 and do your attestation on that 90 days, the security risk analysis that the EP is reviewing, for example, could have occurred prior to the beginning of the 90-day period. That's sufficient, but they still have to have conducted the review and be able to attest to it for that first year of 90-day meaningful use. If any deficiencies are found as part of that risk analysis, then a security update must be put in place to address that security deficiency. Okay, we'll move forward. So the last 3 slides or so have been the formal CMS guidance that they've provided for core measure 15. And I put this in here. This is the reference you see earlier in the definition to 45 CFR 164.308, which is the HIPAA security rule, specifically the administrative safeguard section, and this is how CMS, or I'm sorry, this is how HHS, as part of the HIPAA security rule, has defined risk analysis, risk management, which is really this thing that we've been talking about. That's really, and I mentioned this as I started out the presentation, this really is the degree of specificity that the legislation lays forth and what a risk analysis and risk management process is. As you can see, and as I'm sure you've experienced, it's not particularly specific. It leaves a lot open to interpretation and to required guidance from other sources, and I'll talk about what some of those sources are as we get closer to the end of the presentation. The interesting thing, I've seen a survey done by HIMSS. This was done at the end of 2010, beginning of 2011. And you can see on the right here 3 different years, 2010, 2009, 2008. And the question that was asked by HIMSS was, how often do you, a covered entity, conduct a formal risk analysis? And presumably that formal risk analysis would be something of akin to what's required under HIPAA. And basically what it says is that at least annually, potentially even more often, more frequently, 61%, if you add 8% and 53% the most recent year, 2010, the HIMSS security survey indicated that 61% of the practices who are covered entities under HIPAA were doing a formal risk analysis at least annually, if not more frequently. 81% at least within a 2-year period. When I saw this, that number seemed considerably higher to me than I would have expected had people been answering this truthfully. I did a little sanity check. I actually did 2 sanity checks of this information, one with our HIPAA consultant that we use at MIE, who I work with very closely. And she and I worked together to do the annual HIPAA training. And I went to Joyce and I said, what's your sense from the practices that you cover? Because she has consulting arrangements with a number of practices in helping them develop the appropriate policies. I said, what's your sense in terms of how frequently your practices, the practices that you do business with, are conducting these formal risk analysis? And her assessment was much lower than 61% doing it at least every year. Interestingly enough, this little article came out just on Monday, 3 days ago, and it's incredibly similar to what I just showed you. Joy Kritz, who's the Chief Privacy Officer for the ONC, was presenting back in mid-November, and what I wanted to focus on were these 2 paragraphs right here in the middle. Security and privacy rules associated with HIPAA have been around for about a decade, Joy said. In some of our work, we had somewhat assumed that providers would be very familiar, and what we found, much to our surprise, that's not the case. ONC is counting many providers who have been subject to HIPAA privacy rules for years, but were unfamiliar with how they work. Now that providers are adopting electronic health records, it's being pointed out to them that there is a security rule, actually passed at the same time the privacy rule was. They should have been following for the past 10 years. So even the ONC is getting the sense that maybe not everybody's following the rules. Now, the OCR, the Office for Civil Rights, who's charged with doing HIPAA audits, has not been doing audits and only very recently announced their intent to begin those. So to some extent, providers have been probably watching to see what's happening in the marketplace to figure out whether anybody was really paying attention. I think clearly the message is either they are or they're about to be. The other thing I would mention is that as a result of the Meaningful Use Program, or the EHR Incentive Program, on CMS's website, in one of the FAQs, they make it very clear that as part of the Meaningful Use Incentive Payment Program, they will be conducting audits, not only around security, but around all of the various attestation elements, the 15 plus 5 plus clinical quality measures. They will be doing audits around all of the attestation elements that people are having to swear to as they go through this attestation process. So CMS has made it very clear that all of this is auditable, and I don't think any of us would have been surprised or should have been surprised by that at all. The government is going to spend a tremendous amount of money in this program, and they're going to want to ensure that it's actually being spent appropriately. The other thing I'll mention, and this is not specific to meaningful use, but at the same time, and I just referred to it a moment ago, at the same time we're going through the whole meaningful use security requirement, security risk assessment process, the OCR, the Office for Civil Rights, as part of HHS, has also indicated that beginning in the fall of 2011, now this was published in August, I think they're a little bit behind schedule, not to anyone's great shock, but the OCR has actually awarded almost a $10 million contract to KPMG to help work with them to begin doing HIPAA audits, HIPAA security and privacy audits, beginning in the fall of 2011, or let's say late 2011, and ending in 2012. They're going to do 150 covered entities as part of this initial phase one rollout. So, you know, you can take the number of covered entities in the United States, and I don't have that number off the top of my head, but divide 150 by that number, and that's kind of your odds of being one of the covered entities that's subject to one of these first-round audits by the OCR. And again, this is not a meaningful use audit. This is just the normal HIPAA privacy and security audit. But it's starting. And again, the interesting thing is this is a news item out of one of the electronic feeds, and I found the title interesting. Good news for patients and covered entities. It might be good news for patients. I haven't encountered a covered entity yet that actually had the same perspective on that as the writer here, but they're coming. The other thing I'll mention, if you haven't been through the attestation screens yet, or if you haven't seen the documentation that CMS has posted, this is what Core Measure 15, the security measure, looks like. And I mentioned it before. Here's the objective. Here's the measure, and it's simply yes or no. And again, I can pretty confidently tell you that if you answer no to this question, you're not going to get your meaningful use incentive payment. But the thing you have to understand when you answer yes is when an EP answers yes and goes through the entire attestation process, one of the final screens they get is this one. And I marked two places on here that I think are particularly important. The eligible professional who's about to be paid is certifying that all the information is true, accurate, and complete, and they're also signaling that they acknowledge that anyone who misrepresents or falsifies is subject to federal law and imprisonment, among other things. So basically, here's my point. The security risk assessment, as you saw in the earlier bubble diagram, is not trivial. It's something that should have been done all along. It's not something that's new with meaningful use. What's new with meaningful use is when they came forward with that program, they said, oh, by the way, this is not the language they use, but here's how I've interpreted it. Oh, by the way, those security and privacy, the security risk assessments that you've been obligated to do under HIPAA for some number of years now, please don't forget to add a review of the electronic security capabilities of the technology you're using as part of those normal, regular security risk assessments that we know you're already doing. Now, I'm being a little bit facetious and using maybe some extreme language, but essentially that was the tone of the requirement. That when meaningful use came out and they published Core Measure 15, they didn't say we're going to start requiring you to consider security and privacy now that you have electronic health records. What they really said is we want to expand on the requirement that's already there and make sure that you take into account the electronic side of this. What I don't think the government really anticipated is that the uptake on doing those security risk assessments that were supposed to have happened with the enforcement of HIPAA in the early 2000s may not have been happening. And I, as an eligible professional, would not want to go through and attest to meaningful use, including Core Measure 15, and essentially sign off on the fact that I understood that this was subject to federal laws and fines and imprisonment if it was inaccurate. I don't think I'd want to do that if I couldn't honestly say that I had either conducted or reviewed a security risk analysis that had been done within the last 12 months. To me, and I've offered this in a few presentations and nobody's disputed it yet, I would think that would be akin to Medicare fraud, which seems to me something that an eligible professional would probably not want to get linked up with. So, but that's just my impression or my opinion. In terms of recommendation, this is where it gets a litlittle interesting because I've mentioned this a couple of times now. A risk analysis and a risk management process is something that means different things to different people, and there's no necessarily, it's not black and white, and there's no specific right process. There are a number of good pieces of information or resources available, and I'll give you a resource list here in just a moment. This happens to come from the HIPAA Security Series number 6 that CMS had published some time back, called The Basics of Risk Analysis and Risk Management. I would encourage you to look it up and utilize it. They identify risk analysis essentially as identify the scope, gather the data, and basically determine what exposures you have based on some guidance that they give you in that documentation. That's the risk analysis piece. The second piece of it is, now that you understand what the risks are, and again, taking into account the technical risks around electronic health records as well, what's your plan look like to reduce those risks? You're never going to eliminate all the risks of the information. That's virtually impossible. But the goal is to put a risk management process in place that allows you to reduce those risks to an acceptable level. So risk analysis, that's basically gathering the data and understanding what threats exist. And then the risk management piece is, excuse me, what things are you going to put in place, security controls, policies, et cetera, to minimize those risks. Risk analysis is part of the HIPAA security rule. We've mentioned that. And the HIPAA security rule is broken down into administrative safeguards, physical safeguards, and technical safeguards. So basically, the risk analysis and management process should take into account all of these major sections of the 3 elements of the security rule, because that's really what you're doing as part of this process, is to ensure that you've hit all of the high points, you've hit all the requirements that the HIPAA security rule has laid out. And the risk analysis and management process is really the procedure that you would use to ensure that you're hitting all these key areas that are part of the security rule. I mentioned this earlier. The ONC, when they put together the technical requirements that EHR vendors had to certify to get their EHR technology certified for meaningful use, actually put some technical controls into the certification requirements that address some elements that are required under the HIPAA security rule. So these fall into the authentication, access control, integrity, audit logging, and encryption. And these line items are specific requirements that the ONC put in the certification criteria that certified technology had to be able to accomplish in order to become certified technology that was eligible for meaningful use. So the point is, if you're running EHR meaningful use certified technology, by definition, you have to have at least these capabilities built into the technology, or it would not have been certified by the ONC. Now, it's up to you as a user of that technology to actually invoke these controls and to use them effectively. The technology provider who's providing your EHR has to give you this capability. You actually have to meaningfully use it. So that's important to know as well. Excuse me. There are a number of good information sources that you can turn to get information on doing a risk analysis and risk management, going through that process. The first one here I mentioned, I showed some samples earlier of the steps that they outline in this document. NIST has been a great source. The National Institute of Standards and Technology has been a great source of information, including the 800-66 document, but I'll talk more about something that they just released here in just a moment. And I'm sensitive to the time, so I'm going to wrap up here. But there are other places that you can get additional information as well, and these are some of the ones that I like to use, but there are certainly others. And this is the HIM security survey that I showed the one chart from earlier. One thing that was just released earlier this week is a NIST HIPAA security rule toolkit, and I've got a couple of charts in here, a couple of slides, and when we send you the deck, you'll see them. This is just a press release on the releasing of the toolkit. This is the actual website that you go to. It's actually a Windows or a Linux or Mac OS based tool that you can download to your PC, and it actually steps you through the questions that you need to answer in order to conduct a basic security review that would be appropriate under HIPAA. Actually, this is what one of the screens looks like, and don't be scared by this. It caught me off guard when I first opened up a test plan or a test review. This is for what they call a standard review, which is kind of appropriate for an average-sized practice. And this is the tool. This is the screenshot from the tool showing 492 questions that you would have to answer, and they're kind of broken down: administrative, physical, technical, organizational requirements, policies, and procedures. Now, again, this was just announced on Monday of this week and just delivered. I've not had an opportunity to play with it yet, but my point in this is to make you aware of it and to let you know that there is help coming. The other thing I would mention as I finish here is I know that the RECs, and specifically the Arkansas RECs, provide a tremendous amount of assistance in this area as well. So I would encourage you as practices to utilize the resources that you have available, both the ones that the government has published, as well as the ones that you have access to in the RECs and the other organizations that you work with, because that's really going to be the key to getting this process done efficiently and comprehensively. So with that, I'm going to open it up to questions, and we'll address as many of them as we can, and then we'll address any that we don't get taken care of here after the fact.